I don't think that the transition was properly managed. Whether it was even necessary is another question. But as an advisor at the Council of Governors, working a lot on policy analysis, legislative analysis, I look at bills when they come, and I can tell you that we raised very fundamental issues when the four laws, the bills came up. The Social Health Act, the Digital Health Act, the Facility Improvement Financing Act, and the Primary Health Care Act. We raised fundamental issues, and number one, we said that the Social Health Act is trying to create three different funds. One of them contributory, two of them non-contributory. That is, the Primary Health Care Act fund is non-contributory, but is supposed to be funded by the Exchequer. The Emergency, Chronic and Critical Illnesses Fund is also non-contributory and is supposed to be funded by the Exchequer. And so one of the issues we raised was that if these two funds are funded by the Exchequer, why would you deny a Kenyan citizen, a taxpayer, access from these funds just because he has not been fully registered and paid up under the Social Health Act? We say that would not be right. If this is these funds are receiving money from the government, let everybody access that, even if you are not paid up under the Social Health Care Fund. They wouldn't listen. We also raise questions of the big problem under the NHIF was how to enforce contributions from the people in the informal sector. And the minimum at that, under that act was 500 shillings. And we argued, and I will tell you that I think about 2003, myself and another officer from the Council of Governors and two officers from the ministry went for a training workshop in Nagasaki, organized by World Bank, on health financing. And I can tell you there were very good experts. And they told us in health financing, each country is struggling with the best method of pooling money to finance health. And they said there are two methods. One method is to finance health through general taxes. The downside with that, the problem with that, is that health is then forced to go to the negotiating table when budgets are being done, to negotiate with other departments. Quite often, the decision makers on budgets, people at Treasury, people in finance, do not understand the uniqueness of health. And so a lot of times they end up allocating to health less money than health requires. Many times, even that money when allocated, the transfers are delayed, both to the county governments and subsequently to the health facilities. And many of us argue, and I've done this in the counties when guiding them to pass the Facilities Improvement Financing Act, that while in the Department of Roads and Transport, you can put a construction of a road on hold while you are waiting for money to be transferred. In health, you cannot do that. Health operates on an emergency basis and requires money to be available 24 hours a day. So that if an emergency arises, you can go and purchase what you need. And so that creates a problem with the financing health through general taxes. Now, those experts said the other method is insurance. But the problem with insurance is that it is founded on the concept of voluntary contributions, that you must contribute to be covered. And the experts said that in economies where, like ours, a large portion of the population is in the informal sector and are not salaried, it is very difficult to enforce contributions from the people in the informal sector. It is normally easy to deduct salaries from those who are salaried. But in Kenya, you need to know, if you check statistics, the salaried people are just about 20% of our economy. 80% is in the informal sector. But that's not to say those are poor people. Actually, some of the richest people in our country are in those informal sectors. And some of the poorest people actually are salaried people. And so those experts say, in a country such as that, insurance is not the best choice for pooling money to finance health. Because then you will not be able to build a sustainable fund. And what happens is that in such an economy, we will wait when a member of the family is unwell. Maybe they have now said, you have been diagnosed, you need an operation, and they give you a booking in 6 months' time. Then the family says, can we go and register our mother? We start contributing. 6 months down the line, maybe you have contributed 6,000 shillings. The bill comes out 2 million. The insurance pays. Then you drop out, what health workers call adverse selection. Once you have been treated, you are healed, you drop out, you don't continue contributing. Now you pay like that for 3, 4, 10 people, the fund is not sustainable at all. Now, so when we were making this, so those experts say, then faced with that, many countries seek to combine a bit of taxes and a bit of insurance. And when it comes to taxes, they emphasized with a large informal sector, go for earmarked taxes, mostly put on consumables. For instance, and I argued that we do have a tested example in Kenya called fuel levy for maintenance of roads. We are taxed fuel levy earmarked for roads. So the KRA collects that money and simply hands over to the bodies managing maintenance of roads. And so some of us argued, why don't we then go for earmarked taxes for health? If we can earmark taxes for maintenance of roads, why can't we earmark taxes for maintenance of our own health? And we don't have to create a new tax. We may just go to that fuel levy and we say, if it's 16%, 10% will go to roads and 6% goes to health. You have no cost of collecting that money. The KRA just collects, calculates, and gives to SHA that money. And for you to understand that, you will know that even if you don't have a car, you normally jump onto a boda boda. The boda, when the fuel goes up, they increase the fare. So as you jump onto a boda, you are paying for health at no cost of administrative costs, very low. So you could also go for what they call syntax, consumables. If we say things that cause diseases, sugar, sodas, our mothers in the village take a lot of tea. So when you buy sugar for her, if you put a small tax on sugar for health, as she takes her tea, which may cause her problems, she is already also paying for health. I argued this. I even asked the officer we were with in Nagasaki, what happened? I thought we had agreed this is the best way Kenya should go. Why have you people insisted on insurance? It is not going to solve the problems NHIF had, because the fund under NHIF was not sustainable, because people in the informal sector are not easily paying. I can tell you that SHA will not succeed. It will not become a sustainable fund until we accept that maybe we made a mistake at that point and we amend the law to go to what can raise a sustainable fund. And if you go for fuel levy, there may be someone out there who is not salaried but owns 100 matatus on the Kenyan roads. The moment these matatus are on the road, they are fueling, they are helping us to raise money for health, isn't it? Yes. And that person will be paying equivalent to his income from his matatu without you having to do this thing called prox means testing and so on. Now, we raised issues at the Council of Governors. Is there going to be capitation for levels 2, 3, and 4? You are saying these reforms you want to shift from over-concentration on curative services and go to preventive and promotive, palliative, and all that. And therefore you have to shift, we have to invest more in primary health care. If you don't pay capitation to the primary health care facilities so that they can invest in things like outreach, screenings, and all that, then you are not shifting to preventive. And my argument is that the intentions of our law may be very good, but the devil normally lies in the details. Now, when we developed the details on the tariffs, we have something there that is called capitation, but it is not capitation as we knew it. Because capitation was you give money to the facility up front, then the facility invests in that. Of course, health economists have been telling me that encourages the facilities not using that money in health. But then I was saying, okay, if that is the argument, then we must include in the capitation the services that are rendered at level 1 and perhaps link them to a level 2 facilities. A level 2 facility. I saw many community health promoters here. They have been given gadgets. Why don't you link them to the nearest level 2? So that when they deliver services in the community, they record those services, and those services are reflected as services rendered by level 2, which they are linked to, and then that level 2 claims for that money, and then it's able to invest back into the services. Now, those details, we still have a lot of problems. And one problem we have with SHA is that when we raise these issues, and I must confess, when they didn't listen, the Council of Governors someone went to court, of course, with some of our support, and judgment came. They said, you can't deny people emergency services because they are not registered under SHA. You didn't do adequate public participation, go back and do. A meeting was called between the ministry and the council and the lawyers, and I told them, for once, why don't we do what the court is advising us to do? They said, no, we must appeal. So there is an appeal still pending in the court. I want to say a few things as I finish picking from what the colleagues have said. I want to add on what the lady economist said, that you need to know that the Ministry of Health and SHA had costed primary health care at about 67 billion, but our members of parliament, in their wisdom, they thought they should allocate 4.1. Those were statistics that we were given by the ministry. They had costed the emergency and chronic and critical illnesses fund at about, I think, 107 billion, but they were allocated only 2 billion. So as we talk about accountability, when the budget is being done, the people ought to really face the members of parliament, particularly the members of the National Assembly. That if you really care about your voters who access health services in level 1, level 2, 3, and 4, then you must allocate adequate money to the primary health care fund and also to the emergency, chronic, and critical illnesses fund. Now, the second issue I wanted to mention is, which again has been mentioned about, the role of parliament in as far as accountability is concerned. I am sure all of you must have been surprised to watch our members of parliament appearing surprised about the contents of the SHA law, and yet they are the ones who passed it. We have a very serious problem with that institution, because you can't be the ones who are supposed to scrutinize the bills and pass them into laws, and when they have become laws, you get surprised that the laws are saying what they indeed are saying you passed. So we need to address that issue. It's a serious matter. Now, finally, if Odhiambo can allow me, I want to scribble a few things on the flip chart to help us understand where we are missing on health in terms of what the health workers call the pillars of health. When I came into health 4 years ago at the Council of Governors, I started reading in literature, and I find those pillars are thrown in there in the literature without organization. But from a lawyer's perspective, I decided, can I organize them? Perhaps then we will be able to know how they are interlinked, interconnected, how they must rely on each other. And so we invest in understanding all of them. Maybe you can just put it even here, and I'll be able to do. So in my organization, I said at the top, we have the pillar on health quality service delivery. That is the top. It is the goal we are aiming at. Then next to this are a number of other pillars which facilitate the delivery of health, the quality health services. Here you have human resources for health, HRH. You need human resources to facilitate quality health services. Then you have health products and technologies, drugs and other supplies. They facilitate quality health service delivery. Then you have health infrastructure. Then you have health information systems. Then you have health research. All these are pillars or so-called building blocks of health. All of them are necessary in facilitating health quality service delivery. But these ones must also be facilitated. So below these, you have number 3, which I call health financing. A very important facilitative pillar. It facilitates all the pillars here so that these ones may be able to facilitate quality service delivery. So finance is critical in everything. But below this, we have what we call number 4 is health governance and leadership. Decisions on whether we should prioritize HRH or prioritize financing HRH or HPTs or infrastructure and all that are made within a governance framework and by certain leadership structures. Now, my complaint with health has been when we adopted devolution, the health workers went into self-denial and declared devolution an enemy. Said it has come to destroy health. Are we together? And refused to invest in understanding the new governance framework within which they are supposed to deliver health. They failed. They refused to invest in that. Asking questions, so how are functions shared in this new system? Where are most of the health functions falling? And in this distribution of functions, who is the major employer of health workers? How is money shared in this new governance framework? And if the counties are now the major employers of health workers, do they get adequate money in the division of revenue? Or are we ending up with a lot of money remaining in the national government when the workers have gone to the county governments? These are questions we need to address ourselves. When the division of revenue is being done, most of the times health workers will be on the side of the national government. And then we end up with a lot of money in MOH. Then when that has ended, they come to the counties telling them, employ more workers, promote those who have qualified to promote, and yet they have been given less money. If we understood the governance framework, we would know when to form which strategic partnerships with which level of government at which stage. If it is division of revenue, you push, give counties more money. When the money has come, now you can go to the counties and tell them, now we have helped you to bring more money. Can you do A, B, C, D? You need to understand, the health workers started by saying, how can we be supervised by MCS? In the new governance framework, they are the ones who must pass a budget at the county level, isn't it? And allocate money to health. So you must learn how to influence them. You must learn how to help them to understand the uniqueness of health and why health needs more money. Now, I normally then say, having done this, you may think I started with this. But then if you draw a pyramid, where is the foundation? Yes. The foundation is governance and leadership. Then you come to health financing. Then you come to those others, and the pinnacle of the pyramid is the objective. The poverty of this country is not in the finances and other resources. The poverty of this country is here.
It is not in a deficit in the natural resources, in the finances. The poverty of this country is in the deficit of the integrity of our leaders. That is where we need to focus. The leadership we have. This country has enough money to finance health. How many of you read the news from the cabinet in Kakamega? It was circulating. They had a document on the decisions that were made in Kakamega. And some of those decisions included abolishing certain parastatals, matching some. And I can tell you, this is a subject I've spoken about for the past 10 years. I kept saying, we adopted a new governance system, which required us to deconstruct the old structures and construct the new ones. But we chose to patch the new structures on top of the existing structures. The end result has been duplication of responsibilities and of expenditures. That's why we don't have money. I kept saying, health is devolved, water is devolved, agriculture is devolved. Why do we keep regional development authorities? Nobody will listen. If you read the cabinet decisions from Kakamega, they eventually have now said some of those parastatals must go. In 2013, Uhuru Kenyatta appointed a task force chaired by Abdikadir for parastatal reforms. That task force sat, gave a report which said a number of those parastatals must be abolished, some must be merged. Nobody wanted to implement that report. That cabinet decision now, because they see there is no money, they finally now have said, we must implement, and some of them are going. And if you read that report and you see even the names of some of the parastatals duplicating each other, you will be shocked. And we have been allocating money to them. We have enough money, which we have refused to organize how we should use it, how we should use. So going forward, we focus on that. When the budget is coming, now Trump has said no support from America. We should be asking ourselves, this thing we have put in Parliament called Women Fund, why don't we just put it in health? It is women who are suffering these health issues, isn't it? Why don't we just move it to health? Youth fund, whatever. If we said now, Trump has said this, can we reorganize our budget? We have money to do that. Finally, if we focus on this, one of the things, and recently, towards the end of last year, we had a meeting in Naivasha with governors, high level, even with the Minister for Finance there. And one of the papers I was presenting was on the financial implications of national government policies and legislations. And I went through and I said, across the world, literature shows that implementation of policies and laws fails when we do not audit those policies and legislation at the making stage for financial implications and provide for a budget for them. And I asked the question, does our constitution envisage that problem? And I said, yes, we have a provision in our constitution called money bills. The concept of money bills in our constitution, which can be an accountability mechanism for parliamentarians when they are passing these laws, is to look at the bill. The speaker is supposed to look at it and ask himself, is it a money bill? If it is a money bill, the constitution says it must be dealt with in a special manner, which includes it being given to the Minister for Finance to audit it for financial implications. We also includes it being given to the Appropriations Committee to audit it. And I told the members, the 4 laws in health, were they treated in Parliament as money bills? The policies, and I started with the Kenya Kwanza policy, the manifesto, which promised so many reforms in health. And when it came to financial implications, that policy said these reforms will be budget neutral. Young lady, budget neutral means it will not require more money, isn't it? Did they tell us the truth or did they lie? Then from that Kenya Kwanza manifesto, we come to the laws. When they started and they were in a hurry to pass them, the health, social health, and the digital act bills started in the National Assembly. The memorandum disclosed their money bills. But when it came to considering them, they were not considered as money bills because the standing orders of the National Assembly have draw a distinction between government bills and private members' bills. And those standing orders, unconstitutionally, in my view, say that the Speaker can exclude government bills from going through the process of money bills. So they were not treated as money bills. The primary health care and the facility improvement financing commenced in the Senate. And because they have always thought money bills means a money bill cannot originate in the Senate, and this time they were in a hurry to get these things passed, so they said these other two should originate in the Senate. The memorandum said they are not money bills. And then when you go into the financial implications for citizens, huge. People in salaried employment moving from contributing 20,000 per year to now about 300 and something a year. And you go to the hospital, some of the things are not covered, and you are left. Going forward, I told these people, can we then ask ourselves, with the devolution, should money bills only be sent to the Minister for Finance at the national level, or should they also be sent to the counties? Because many of these national government policies and legislations create additional financial obligations for counties without providing the additional money.